Hi, this is Shilpa Paul. I'm a clinical pharmacy specialist at the University of Texas at MD Anderson Cancer Center. I'm going to discuss Gemtuzumab Ozogamicin and its adverse effects in management. Just to briefly describe Gemtuzumab Ozogamicin, it is a humanized CD33 antibody drug conjugate, and CD33s are ideal targets for therapy because of their high level expression on AML cells. Gemtuzumab in itself is a IgG4 antibody that is linked to cytotoxic calicheamicin, which is producing the anti-leukemic effect. It is linked by an acid labile linker. Gemtuzumab Ozogamicin, when it's bound to CD33, gets rapidly internalized, and then calicheamicin is cleaved off of the construct, and this essentially binds to the minor groove of the DNA, causing DNA strand breakage and essentially causing cell cycle arrest and apoptosis. There have been several trials that have proven its efficacy and safety in both monotherapy and in combination with chemotherapy. And this is just briefly describing some of the trials and what we basically have learned, that the lower dose, the 3 milligrams per meter squared fractionated, is both effective but also safe, and that patients that have favorable and intermediate risk cytogenetics tend to benefit more from Gemtuzumab Ozogamicin. It is approved in newly diagnosed AML as well as relapsed refractory AML. Its dosing is slightly different based on whether you are going to combine it with therapy or use it as a single agent. It is a intravenous solution, so it's given through an IV over 2 hours using a filter, and when administering the drug, it does need to be protected from light. Gemtuzumab Ozogamicin is about 97% bound to plasma protein, so it's highly protein bound. Calicheamicin goes through a non-enzymatic reduction, so there isn't really any dose reductions or dose modifications that need to be done for just moderate to mild renal impairment or hepatic impairment, but it's not really well studied in severe hepatic or renal impairment. I want to just now briefly discuss some of the adverse effects that we are able to mitigate, and it's very important to monitor for these adverse effects as well. So the first one is infusion-related reactions. Gemtuzumab is a humanized anti-CD33 antibody, so it will have some reactions, infusion reactions, so you need to be monitoring the patients, and these are usually the nurses or people that are administering the drug. And it is very important to pre-medicate before every infusion of Gemtuzumab, so you want to give the patients acetaminophen, diphenhydramine, or steroids at least 30 minutes prior to the infusion. Be monitoring the patients for vital signs and any kind of infusion-related reactions throughout the infusion. You can decrease the infusion rate if the patient does have a reaction, but if it's a life-threatening reaction, then you do want to discontinue the infusion. Gemtuzumab Ozogamicin has also been linked to some cardiotoxicity, particularly QTc prolongation, which has said to be linked to more of calicheamicin because it's been found in other calicheamicin-containing product. Usually just want to get a baseline EKG prior to starting Gemtuzumab, but it doesn't need to be routinely done throughout or prior to each Gemtuzumab dosing. But you do want to monitor the patients and make sure you want to replace their magnesium and potassium if needed, as well as avoiding any other concomitant QTc prolonging medications. There is a box warning for hepatotoxicity because it can increase ALT and AST, so you do want to hold the drug or delay the infusion if the patient's T-billy is greater than 2 times the upper limit of normal, or if their AST and ALT is above 2.5 times the upper limit normal. You can restart it once T-billy or AST and ALT has normalized. It has also been linked to hematologic toxicity, especially if it's being combined with other chemotherapy regimens. Calicheamicin has been linked to thrombocytopenia, so both thrombocytopenia and neutropenia can result. So if the patient's platelets are still less than 100,000 or ANC is less than 500, then you want to skip the next Gemtuzumab dose because you do want their counts to recover. So you can forego that if they haven't recovered within the 14 days prior to giving to the second dose of Gemtuzumab. Other adverse effects are rash, some GI intolerance such as nausea, vomiting. mucositis and constipation. It can happen more in combination with other chemotherapy regimens, hematologic toxicity, as well as hepatotoxicity, as I mentioned earlier, as well as headache has been reported. Now, I briefly want to focus on sinusoidal obstructive syndrome because if it does occur, although rare, it does have a 70% mortality rate, so it is very important to be monitoring and be cognizant of this adverse effect with Gemtuzumab Ozogamicin. Its prevalence is 10%, and we know that there have been hepatocyte necrosis and there has been sinusoidal injury when we have looked at the pathology reports of getting liver biopsies from the patients that have gotten Gemtuzumab Ozogamicin. Usually patients present with ascites or fluid retention. They'll have painful hematomegaly, and the weight gain is usually from their ascites and fluid retention. Increase in T-bili can also occur. So we haven't exactly pinned down the exact cause, but there are several theories as to what is causing this SOS. The first one being that there is CD33 expression on Kupffer cells as well as sinusoidal endothelial cells. The second being that unconjugated calicheamicin is what is causing this injury, or that there is just non-specific uptake of these antibody drug conjugates. Usually the way to manage it is prevention, as we have learned that higher dose, 9 milligrams per meter squared, has caused more of the SOS, and there is a lower prevalence with the lower fractionated dosing, and also that if patients get transplanted after Gemtuzumab, their preparatory regimens such as alkylating agents or busulfan, if that is used, then there's a higher incidence of SOS. So in order to prevent those things, we want to use lower fractionated dosing of Gemtuzumab, and we also want to avoid giving patients a transplant at least 2 to 4 months out from the last dose of Gemtuzumab, and we want to try to avoid as much as possible anything preparatory regimen that contains like alkylating agents or busulfan. As far as the treatment is concerned, you want to discontinue the Gemtuzumab Ozogamicin. Usually SOS presents about 5 all the way to about 20 days after the dose is given, so there's quite a range. And then defibrotide can be used if clinically indicated in patients that you truly know have SOS. So this has been some of the adverse effects and the management of Gemtuzumab Ozogamicin. Thank you.